33.3.4 Bell's palsy. General and format iron. Bell's palsy, BP, also known as idiopathic peripheral facial palsy, BFP, is the most common cause of facial paralysis, 50–80% of PFPs. In ciden c. 150–200/1 Etiology, by definition, PFP is called Bell's palsy WHN. It is not due to not our causes of PFP, for example infection, dumor or T raum, and ehrno author and eurological, for example involvem of author cranial nerve, or systemic and ifestat ins, for example fever, diabetes, possibly hypertension. 13. 14 thus, true BP is idiopathic, and D is a diagnosis of exclusion. Most cases probably represent a viral inflammatory yelin atin G polyn euritis. 15 usually due to herpes simplex virus. 16 Facial palsy due to Lyme disease can usually be recognized on clinical ground. DS. 17 Severity may be graded on the House and Brackm and grade in G scale, see table 41.3. Present diagn prodromy is frequent myalgia, hypestesia or dysestesia of thet trigeminal nerv, n/v, diarrhea. Paralysis may be incomplete and D remain so. Type I, it is complete at onset in 50%. Type A, the remain der progress to completion in 1 week. Usually exhibits distal to proximal progression, motor brand chs. THNCH or T-ban, loss of taste and decreased salivation, THN stapedial brand CH, hyperacusis, THN generaliculate ganglion, decreased tearing. Associated symptom SRSHRN in table 33.2, and are usually, but are not always, ipsilateral. Herpes zoster vesicles develop in 4% of patient ES 2–4 days after onset of paralysis, and D in 30% of patient ES 4–8 days after onset. During GTHE recover YBHA's excessive lacrimation may occur, aberrant nerve regeneration. 33. Evaluate iron patent TSW with BFBS8 will be examined at an early stage to optimize outcome. Electrodiagnostics, may detect tree in innervation potentials, aids prognostication. Nerve conduct iron study, electrical stimulate iron of the facial nerve near THEST lomastoid forum NWHEL recording gin facial muscles. A facial nerve may continue to conduct for up to 1 week even after complete transection. Table 33.2 Associated symptoms with Bell's palsy symptom facial and retro-auricular pain dysgeusia hyperacusis reduced tearing percent 60% 57% 30% 17%. http://esurg.com 578. Neurophthalmology and neurotology. Management. General measures. Protection of THEI is critical. Artificial tears during GTHE day, on trademark NT at NIT, avoid brig T light E, use in G dark glasses during GTHE day. Medical management. Steroids, prednisolone 25 mg/po. Bid 10 days, started within 72 hours of onset of symptom S, improves THECH and C of complete recover Y at 3 and 9 m on THS. Acyclovir, does not help, alone or in combination with prednisolone. 18. Surgical management. Surgical decompression, controversial. The definitive study has not been done. Rarely utilized. Indication may include, 1. Complete facial nerve degeneration without response to nerve stimulation, Although th's absence is also used as an argument against surger y9, 2. Progressively deteriorating g responsato nervst emulation 3. No clinical nor objective, nerv test in g, improvement after 8 wks, however, in cases the diagnosis of Bell's palsy is felt to be certain. The active disease WLH avenue abated by 14 days after onset 9 prognosis essentially all cases SHOSOME recover Y, if N on E by 6 MOS, author etiologies S Palsy T. Extent D of recover Y, 75–80% of cases recover completely, 10% party al, remainder poor. If recover Y begin S by 10–21 D, tends to be complete, if not until 3–8 wks fair, if not until 2–4 MOS poor recover Y. If a paralysis is complete at onset, 50% WLH avenue incomplete recover Y. Cases of incomplete paralysis at onset at do not progress to complete paralysis complete recover Y. Incomplete paralysis at onset at progresses to complete incomplete recover Y in 75% of WOS prognosis is associated with M or proximal involvement, hyperacusis, decreased tearing, age 60s, diabetes, HTN, psychoneurosis, and oral, facial or radicular pain. 33.3.5 Herpes zoster oticus facial paralysis. 33. Symptoms are more severe TH in Bell's palsy, hepatic vesicles are usually present and D antibody-titers to varicella zoster virus rise. THS patient ESH avenue HI risk of facial nerve degeneration. 33.3.6 Surgical treatment of facial palsy general information for cases with focal injury white THE facial nerve, for example trauma, injury y during G surgery y for part or more, dynamic reconstruction by nerve anastamoses are usually considered superior to static methods. 19 For non-focal causes, for example Bell's palsy, only static methods may be applicable. A fun ctin eural repair is not possible if THE facial muscles have atrophied or fibrosed. Surgical options. Surgical treatment options include 1. For intracranial injury white facial nerve, for example during G party or surgery, intracranial reapproximation, W with or W without graft. Os THE best hope for THE most denom facial reanimation TMing a TME of or removal, for a divided facial nerve during G removal of vestibular SCH1 enom 20,21,22, THE best result TH can be a W with TH's is House Brackm N grade A. THE operation fails to produce good results in 33% of cases. 22 In delayed fashion, especially if THE nerve W is left in anatomic continent YB, tech NX directory anastomosis, decult due to THE frail enatrov THE nerve, especially WHNIDH has been stretched by a tum or cable graft, for example using G greater auricular nerve 23 or seral nerve. http://esurg.com. Neurology. 579. 2. Extracranial facial nerve anastomosis A. Hypoglossal nerve, CR. N. Xiphacial nerve anastomosis, see below, B. Spinal axis Y nerve, CR. N. Xiphacial nerve anastomosis, see below, C. PH renic nerve facial nerve anastomosis D. Glossopharyngeal, CR. N. X facial nerve anastomosis E. Crossface graft in G. Vivae, results H avenue not been ver Y good 3. Mechanical or static amian SA. Facial suspension, for example W with polypropylene E, Marlex registered, Mesh 24B, eye closure techniques, protect SDHEI from exposure and de-reduced tearing, darcerophy, partial or complete gold WATS in eyelid stainless steel springy in eyelid. Timing of surgery if THE facial nerve is not our to be interrupted, for example ransected during removal of vestibular SCH1 anoma, THN early surgical treatment is indicated. WHN-THE status of THE nerve is not our or if incontinent Y but not fancy TIN in G. DHN several M on THS of observation and D electrical test in GSA old be allowed for spontaneous recover Y. Ver violatum PTS atinus to Moses H avenue SCH and C for recover Y due to facial muscle atrophy. Hypoglossal nerve facial nerve, ZIV, anastomosis general information cannot be used bilaterally in patient ESW with facial diplegia or in THSW with otherlo-cranial nerve deficits, or potential for SAME. In spite of SAME suggestionness to THE contra Y, sacrificing THE's nerve does create SAME morbidity Y, dungatrophy W with D cult twice speak and G. Emastication and D-swallow in G in 25% of cases, exacerbated WHN-THE facial muscles do not fancy TIN non-TH at side, aspiratin may occur if vagus, CR. N. X, dysfancy TIN coexists W with loss of Z. Not as active as it doubled THE or ethically seem possible. THE resultant T facial reanimation is often less than ideal, may permit MS involvem NT. To avoid severe disappoint trademark NT, THE patent SA alt early understand DTHE likely side acts and DTH at THE facial involvem NTW will probably be a much less DHN normal, often W with poor voluntary control. Usually performed in conjunction W with anastomosis of THE descent NS hypoglossy to THE distal hypoglossal nerve to TRY and D reduce amyotrophy of THE ung. Atrophy may also be reduced by using a jumpy graft W without completely interrupting GZ.25.